Hi everyone, we have successfully made it to the last day of class, so let's get started on our presentation about dementia. Dementia is a neurodegenerative disease accompanied by cognitive impairments and affects 5.7 million people in the United States. Although dementia mainly affects older individuals, typically around the age of 65, it's important to note that dementia is not a normal part of aging. Disorders grouped under dementia are caused by changes in the brain and are characterized by a progressive decline in memory and other cognitive domains that, when severe enough, interfere with daily living and independent functioning. Dementia is an overall term, not a single disease, and covers a wide range of specific medical conditions, including Alzheimer's disease, Lewy body dementia, vascular dementia, and frontotemporal dementia. Dementia is a progressive disease where symptoms start out slowly and gradually get worse over time. For a better visual representation of the most common causes of dementia, we have created a pie chart for you guys. Alzheimer's is represented in the chart by the blue section and compensates for 60 to 90% of dementia cases. Vascular dementia is the second most common cause of dementia and compensates for about 10% of cases. This dementia is caused by bleeding within the brain from stroke-caused damage. As you will shortly find, symptoms of vascular dementia coexist with Alzheimer's, which sometimes makes it hard to distinguish between the two in early stages. Lewy body dementia is the third most common cause and compensates for about 5 to 10% of cases. This dementia leads to a decline in thinking, reasoning, and independent functions and is often found in individuals with Parkinson's disease. Symptoms often include sleep disturbances, memory loss, delusions, hallucinations, and varied alertness and confusion. Lastly, frontotemporal dementia accounts for fewer than 10% of cases and is unique in its deficits, as learning, memory, and perceptual motor functions are often spared. Unlike the previously discussed dementias, frontotemporal dementia is characterized by behavioral and emotional changes rather than cognitive impairment. This occurs when the frontal or temporal lobes shrink or become damaged. Again, it's important to note that with these causes of dementias, the diagnosis cannot be cured or reversed, but rather therapies and treatment can be implemented to improve the individual's quality of life and to maintain intact abilities for as long as possible. As mentioned in the previous slide, Alzheimer's accounts for 60 to 90% of dementia cases. It's caused by microscopic changes in the brain. A buildup of plaques and tangles spread throughout the brain, damaging and killing the nerve cells that are needed to ensure the different regions of the brain are working properly. Plaques are abnormal clusters of protein fragments that build up between nerve cells. They form when protein pieces called beta amyloids clump together. They are known as being chemically sticky and will gradually build up into a plaque. When the plaque begins to damage the nerve cell, they die and release tangles. Tangles are made up of a twisted strand of another protein and destroy a vital cell transport system made of proteins. The formation of tangles prevents the nutrients and other essential supplies to move throughout the cell, and the cell will eventually die because of the lost connection. The hippocampus, which we know is responsible for learning and memory, is extremely vulnerable to damage from plaques and tangles in Alzheimer's disease. Plaques and tangles begin their buildup in the hippocampus and gradually spread throughout the brain as the disease progresses. With the hippocampus being the first area impacted by this disease, word retrieval and memory loss are commonly the first deficits present in an individual with Alzheimer's dementia. We provided these pictures as a visual for you guys to see how the plaques and tangles grow and spread and ultimately affect the brain in Alzheimer's disease. In the top picture, the darkness of the blue shaded areas depict the presence of plaques and tangles in the brain. In the earliest stages of dementia, you can see that the hippocampus is beginning to show signs of plaques and tangles. This is why short-term memory and word-finding deficits are often the first symptoms of Alzheimer's dementia. You can also see that the plaques and tangles are spreading to the frontal lobe of the brain and are beginning to affect thinking and planning. The middle picture represents the mild to moderate stages of Alzheimer's, where you can see that the plaques and tangles are spreading and creating deficits in speaking and understanding speech, as well as impairing the ability to have a sense of where your body is in relation to objects around you. The presence of plaques and tangles in the hippocampus are becoming greater, and deficits will begin to interfere with work or social life. An individual in this mild to moderate stage of Alzheimer's may begin to confuse words and act in unexpected ways because the symptoms are becoming more pronounced and the damage to nerve cells are becoming greater. As this disease progresses, higher level of care will be required. The picture on the top right portrays advanced Alzheimer's disease, and as you can see, most of the cortex is now severely damaged. Individuals have now lost their ability to communicate, recognize family, friends, and loved ones, and are unable to care for themselves. Due to the widespread cell death, the brain begins to shrink. Shrinkage of the brain is shown in the picture below. On the left, you can see a brain without the disease. The middle picture shows the shrinkage as a result of the buildup of plaques and tangles. Then you can see in the far right picture how the two brains compare in size. By the size difference, you can infer the impairments that an individual with Alzheimer's might be facing. We hope that this visual will help you understand Alzheimer's throughout the next few slides as we go more into depth about the different stages. The progression and debilitation of Alzheimer's dementia affects cognitive functions that include language, visual spatial skills, attention, orientation, executive functioning, and more. Alzheimer's progresses in 3 general stages. These stages will be discussed more in the coming slides, but can generally be referred to as early, middle, and late, or mild, moderate, and severe Alzheimer's. Language impairments in Alzheimer's are a result of decline in semantic and pragmatic levels of language processing. We will provide examples of these impairments in the coming slides, but it's important to note that in early stages of Alzheimer's, lexical retrieval and loss of fluency are common, while in severe Alzheimer's, speech can be restricted to echolalia. Declarative or explicit memory is affected the most in Alzheimer's dementia. An individual with Alzheimer's typically begins to present with deficits in episodic, semantic, and lexical memory, while procedural memory remains intact. To paint a picture for you guys, someone presenting with Alzheimer's might be unable to remember their wedding anniversary, but will have the ability to independently take a shower or shave with just some minor guidance or encouragement.
According to the Acquired Language Disorders, a Case-Based Approach textbook, the stages of dementia were discussed in relation to the percent of functional ability and subcategories of deficits. These deficits included physical senses, cognitive memory, self-care, and communication. A consistent pattern was seen within the chart, showing a decline of abilities over time. Dementia is a progressive disease, meaning deficits will become worse with time. Within all categories, the percentage of functional ability decreased from early to middle to late stages of dementia. For example, physical abilities such as activities of everyday living started functionally at 80%. In early stages, patients with dementia are able to physically function within society through simple activities, such as driving. Yet, when the patient enters middle stage, their functional physical abilities lessen to 60%. Meaning driving or food shopping become more difficult. These difficulties come with cognitive impairments such as episodic and procedural memory deficits. When the patient enters the later stages of dementia, their brain is overall affected by deterioration of the nerve cells, affecting their physical abilities at about 40%. When the patient enters the late stage of dementia, they will often need assistance to complete daily activities of living independently. As you can see within the chart, all categories begin at a functional percentage and slowly decrease with time. When relating to speech, communication is highly affected within dementia and Alzheimer's patients. In the early stage, dementia patients will start at 60% effective communication and deteriorate to 20% by the late stages. Communication tends to become more difficult over time when complexity or length of the sentences or directions become longer. Although patients are often able to communicate short utterances or well-known phrases, communication out of typical context is hard for patients to comprehend. Although each subtype is shown separately, deficits will affect all categories. For example, a patient with dementia in the early stages will be able to read short passages, but due to memory deficits, it's hard for them to remember what was read. Due to communication deficits, it will not only be hard to comprehend what was read, but to communicate abstract concepts from what was read as well. Within the earliest stages of Alzheimer's, before severe symptoms can be seen, Plaques and tangles begin to form in the brain in areas that involve learning, memory, thinking, and planning. A patient within early stages of dementia can define words and describe pictures, but have most difficulty following a line of conversation. The patient will have most functional abilities within activities of daily living. Within this stage, they are able to follow 3-step directions, but have trouble when the directions become longer or more complex. The patient will be able to communicate effectively with correct syntax within their sentences, but deficits can be seen within communication when incomplete sentences or repetitive speech, known as echolalia, are used. Communication is functional, but over time, context will become less meaningful. Reading and writing are still functional, but also become harder with length and complexity. Reading is functional, but patients often forget what is read due to memory deficits. Decreases in skills such as psychomotor or perceptual speed, abstract reasoning, visuospatial skills, and episodic memory are prevalent within the early stages. Throughout the early stages of dementia, deficits become known through activities such as handling finances, complex tasks, awareness of recent events, disjointed conversation, disoriented sense of time and place, and mild semantic dysnomia. When given a mini mental state exam by a neurologist, a patient with early Alzheimer's will score between a 16 and 24 out of 30.
Mild to moderate Alzheimer's affects brain regions that include memory, thinking, and planning. These become affected by deterioration of plaques and tangles. Within this stage, patients begin to experience problems within work and social life. A person with Alzheimer's personality starts to become altered due to deficits. A patient will become confused or disoriented and unable to express their thoughts and emotions. Plaques and tangles that are deteriorated start to spread to regions of the brain that affect speaking, understanding speech, and a sense of where your body is in relation to objects around you, also known as proprioception. Difficulty with conversation and meaningful verbal output are seen. The patient will be able to communicate with the correct syntax, but sentence fragments with longer speech are expected. Because Alzheimer's is a progressive disease, it is expected that someone in the early stages will be able to follow 3-step directions. Someone within the middle stage will only be able to follow 2-step. Deficits within memory and comprehension make reading and writing with length and complexity difficult, although the functional ability of these skills are spared. Personality becomes affected within patients of Alzheimer's through restlessness, distractibility, attention, focus, forgetfulness, agitation, and anxiety. Frustration is expected when the patient is experiencing memory deficits. Problems within episodic memory of events, semantic memory, and greater knowledge of the remote past rather than present are seen. Additional deficits such as visual perception, constructional deficits, cognitive function, word finding, reading and writing are also prevalent within the middle stages. Mild Alzheimer's begins to also affect the person's ability to complete functional everyday activities, usually needing assistance from family members. When given a mini mental state exam by a neurologist, a patient with mild Alzheimer's will score between an 8 and a 15 out of 30.
In advanced Alzheimer's, in late stages, the majority of the cortex is seriously damaged. Due to brain shrinkage and deterioration of plaques and tangles, cell death is widespread. Individuals begin to see deficits in communication, recognizing family members, and the ability to care for themselves independently. Extensive memory loss affects many areas of the patient's life, such as working or declarative memory. Unfortunately, by late stages of the Alzheimer's, a patient will experience disoriented time, place, and factors relating to self. They will also have limited problem solving abilities and minimal functional vocabulary. Remaining language includes social phrases or nonsense words. This frustration could result in a patient becoming mute. Verbal output is diminished or out of context. So, as expected, dementia progresses, so following directions becomes more difficult. By the late stages, a patient will only be able to follow one-step directions. Physical deficits within the final stages start to affect the patient's independence, such as walking or incontinent needs. When given a mental state exam by a neurologist, a patient within the late stages will score low, between a 0 and a 9 out of 30.
Our client is Max, a 76-year-old male who is married and has two grown children who live near him. His family has had some concerns due to his ability to no longer manage his own routine or complete simple tasks, so they took him to a neurologist in hopes of some answers. The neurologist administered a mini mental state examination, which is a screener that evaluates areas that pertain to us, such as orientation, memory recall, attention, naming, repetition, reading and writing, and so on. The findings of this screener indicated that Max received a score of 10 out of a possible 30, which could indicate the middle stages of dementia that we previously discussed. But more assessment is needed to confirm these findings. It is also important to note Max's medical history to move forward. Max has a history of cardiomyopathy, a disease that makes it hard for the body to pump blood, cortical atrophy, hypercholesterolemia, which means high cholesterol, and he has a recent surgery from a hernia repair. This medical history is important to know all of the information for possible factors that could later affect Max in assessment and in treatment. But the most important thing to note that is on his case history is suspected Capgras syndrome, a condition where you do not recognize your own family members. Max's wife claims that Max has been suffering from this condition and often does not recognize her and considers her an imposter. After the neurologist obtained their results, Max was referred to us as speech language pathologists in order to affirm these suspected deficits. In an extensive interview with Max and his family, we utilized the clinical dementia rating scale to obtain important information about Max's impairments. Both Max's wife and Max himself provided answers to questions on the forms. We then used our own clinical judgment to decide what severity range Max fell in. From building rapport with Max, listening to his family's concerns, and completing the form, we learned that Max is a World War II naval officer veteran who, since his service, has worked in the trucking business. Being that Max is now retired, he has more leisure time to take up activities he enjoys, such as gardening, home improvement projects, and cooking. Max's wife, however, is concerned about his ability to attend to these tasks for a long period of time and is growing concerned that his safety could be compromised in the process. Max's family also raised concerns about his ability to complete simple calculations, telling time, and complete other tasks that otherwise in the past he had no difficulty with. It's important to note that Max has become increasingly more isolated and gets overwhelmed when conversing with a group of people. Because of this, his social interactions have been limited to immediate family members. His wife also mentioned that he grows irritated if people bring up his deficits to him. Getting to know Max on a personal level and understanding the communication that currently exists between him and his everyday communication partners is essential to know in moving forward. After administering the clinical dementia rating scale, we decided next time we see Max to administer the Arizona Battery for Communication Disorders of Dementia 2, also widely known as the ABCD2. This comprehensive battery assesses the cognitive areas and language skills impacted by dementia, making it an appropriate standardized measure to use for a client such as Max. This list you see here are also standardized assessment measures that the textbook mentions for evaluating dementia. As you can see, we also highlighted on the screen the mini mental state examination and the clinical dementia rating scale because those are the assessments that we already administered to Max.
Now, moving forward, we plan to administer the ABCD2. However, as many of you are very well aware, assessment, planning, and treatment do not always go the way we would expect. Considering the times we live in today, we thought it would be a valuable addition to our presentation to note the other possible avenues that could be taken if the unexpected occurs. Therefore, because of extenuating circumstances, we were not able to administer the Arizona to Max. This is because of our inability to assess Max in person as we previously planned on doing. Having this no longer be an option, we had to rethink our approach. We investigated evidence-based approaches to evaluating Max so we could move forward with appropriate goals and treatment plans. Even though telehealth is not delivered face-to-face, it still has components that make it reliable and an essential tool in administering assessment or therapy in times when needed. Some benefits worth mentioning are that it can provide assessment and treatment sessions in a natural environment. It can also reduce travel costs for patients and SLPs. It is also possible to treat more patients in less time using this method. And finally, a number of patients needing SLP services is expected to increase, so telehealth could provide a good solution for future need. Obviously, we prefer to evaluate our client in person, but because this is not an option at this time, telehealth seems to be the right alternative. Through telehealth, we are now instead administering the Montreal Cognitive Assessment, or otherwise popularly known as the MoCA. There is great evidence that indicates that the MoCA can be reliably administered online. The official MoCA website cites up to 5 studies, including one by Nathaniel DeYoung and Brian Chanel, that studied the screener's efficacy of administering it online through telehealth with veterans. Now that we have some credible evidence on this communication modality, we can have Max complete the screener, which is the additional handout attached. Because of Max's attention deficits, the shorter screener may actually give us a more well-rounded picture of Max's abilities in these areas, instead of spending a long period of time on one subtest and having him lose focus. Max's score on the MoCA indicates a moderate cognitive impairment, scoring an 11 out of 30. This score aligns with the neurologist's findings in the mini mental status examination screener. It's important to note, though, that the screener also evaluated many areas of weakness for Max, which could explain to a certain extent his low score. However, this information still leads us to believe that he is experiencing deficits related to Alzheimer's, even though no diagnosis can officially be declared at this point in time. Max scored most poorly on tasks related to delayed recall, working memory, visuospatial, and executive functioning skill sets. Despite not having an official diagnosis of Alzheimer's, we're still going to present the treatment Max would receive from an Alzheimer's diagnosis because of the deficits he currently presented with and the information we obtained from assessment. Formal assessment, though, would then have to be carried out directly following the lift of safety measures currently in place due to COVID-19. The ALD target model provides a very good representation of Max's strengths and weaknesses, skill sets corroborated by the screeners we previously administered. As you can see, Max's cognitive functions such as attention, memory, executive functioning, and visuospatial skills are crossed off, indicating impaired cognitive function. Reading, writing, comprehension, and expressive language are all equidistant from the language square on the ALD model. This indicates mild impaired cognitive functioning. Sadly, over time, strengths of Max will decline due to the nature of the degenerative disease with no known cure. But for right now, Max still presents with some overall strengths, including utilizing simple sentences in his speech and other corresponding elements of his speech were found to be within normal limits. His reading at the word level, identifying objects and their functions, and procedural memory tasks have still aided him in performing certain activities of daily living. We have found that Max's language is most functional when the words are common, spelled regularly, and when the language is non-complex. The more advanced the language becomes, and when it is starting to be used at the sentence and paragraph level, his ability to comprehend becomes more impaired. Language also becomes a problem for him when discussing facts, dates, and times, including in history, social events, and facts relating to himself and loved ones. Max's biggest area of concern at the moment is his cognitive abilities that are impaired, as we previously discussed. It's evident that Max's deficits are more noticeable when he has different communication partners or depending on the time of day of the conversation. That is when linguistic overload and communication breakdowns occur for Max the most. You will see how we address these issues in treatment as the presentation progresses.
Another model to consider is the International Classification of Functioning model. This chart displays Max's current deficits and factors that affect his daily activities and overall functioning. This information provides a framework for Max's individualized treatment, as all aspects of the model will be important in creating goals to provide the best therapy. At the top is Max's suspected diagnosis of Alzheimer's disease. His moderate cognitive impairment affects his attention, word retrieval, executive functioning, and visuospatial skills, as well as his deficits with his short-term memory. Max often becomes frustrated and withdraws into silence in social interactions and has difficulty following multi-step directions. These deficits impede on his ability to safely complete routine tasks, such as home repairs, and be an active participator in conversations with his wife and in small groups of people. Max's personal factors are that he is a 79-year-old male, he is sometimes irritable, and shows signs of Capgras syndrome or imposter syndrome. Environmentally, Max lives with his supportive wife, but Max's inability to recognize his wife has put stress on their relationship. Additionally, he experiences behavioral issues related to the time of day, also known as sundowning, and is living in the uncharted world of COVID-19. All factors noted in this model, in conjunction with the ALD model, will drive Max's therapy plan. Max is primarily affected by his cognitive deficits with some minor linguistic problems. All things considered, Max's treatment will be a person-centered cognitive communication approach that combines compensatory and restorative therapy techniques to compensate for his cognitive deficits and maximize his communicative abilities. Compensatory treatments involve teaching or providing specific methods to compensate for deficits that are not retrainable. External memory aids help individuals with memory problems in their day-to-day activities. The use of memory books, communication cards, and environmental modifications help individuals in their day-to-day lives compensate for memory deficits, aid in conversation, and maximize independence. The use of external memory aids will be essential for Max throughout his journey with Alzheimer's disease. Additionally, we will incorporate restorative treatment strategies to directly improve or restore impaired functions through retraining. One technique we will attempt with Max is space retrieval training. This technique allows for Max to learn and store important information in his implicit memory so that it can be easily accessed. A functional target is chosen and is learned through asking the question that elicits the target response over a series of time intervals to eventually have the information stored in the memory. This does not directly improve memory, but the facts or information learned in training will help with generalization for everyday use. Feeding and swallowing is not a concern for Max at this point in time, but as the disease progresses, this should be monitored and intervention will be provided when problems do arise. If these strategies are put in place now at this stage, It will greatly improve his ability to maintain overall functioning in the future. Therapy will occur twice a week in the beginning of treatment to teach and provide strategies and methods to Max and his family. Once strategies are established and in place, therapy can happen less frequently to monitor the effectivity of those strategies, adjust goals, and answer questions as needed. It is important to be cognizant that dementia is a degenerative disease, and treatment and therapy goals will be monitored and changed over time to fix Max's current needs and abilities.
Due to Max's cognitive impairments, it is important to keep in mind the following therapy strategies when administering treatment. Certain treatment strategies that can enhance therapy include using simple sentence structure for syntax, using current information that is attainable through working memory deficits, using slow rate of speech for processing, and using limited communication partners for attention. Staying within the person's line of sight is essential due to the attention and visuospatial deficits. Also, using positive and supportive language can aid in creating a safe and encouraging space for the patient when experiencing frustration. It is also important to incorporate family members within therapy to ensure generalization within the home and natural environments for the patient.
Counseling and education is an essential and major part of Max's therapy. We will provide information to Max and his family about dementia through the course of treatment to ensure his family is well informed while also being cognizant of their emotions throughout. To have continued support outside of speech sessions, we have provided Max's family with the link to ALZ Connected, a free online community where people with Alzheimer's, caregivers, family, or friends can ask questions, get advice, and find support. We have also given Max's wife information for in-person support groups. However, due to COVID-19, all in-person support groups will be hosted via phone or video conference. Training families and spouses how to use effective strategies to improve communication competence and cognitive decline can help assist in the progress of his therapeutic goals and improve Max's overall quality of life. We will provide communication partner training to Max's wife to better conversations with her husband and give her the tools to help Max engage in conversations more successfully. Along with this, we have established goals for Max and his family to create external memory aids for Max to use in his home and communicative environments. The first goal, they will create labels with picture icons for preferred activities and chores to maintain functioning of daily activities. This could include creating a picture icon of someone washing a dish and placing that picture icon above the sink. They will also create a set of written instructions with picture icons on how to complete home repairs and maintain landscaping. This could include simple step-by-step directions on how to fix a leaky bathroom pipe with pictures for visual supports. Additionally, they will create a memory book with photos and names of loved ones to maintain recall and facilitate conversations. Creating the memory book with his wife will hopefully spark conversation of the past to reminisce on, and Max will be able to use this memory aid during conversation. Working with Max and his family through counseling will help them understand and manage changes, provide a supportive environment for Max, and create the tools necessary to help Max now and in the future. Keeping coronavirus in mind, providing important information and completing these goals can be easily managed through online mediums with telehealth. We have established a few short-term goals for Max to achieve that align with the goals for family counseling. These goals can be carried out and monitored through telehealth if needed. Max will utilize the external memory aids and communication strategies to successfully complete his activities of daily living. Max will sequence 2 to 3 steps instructions using the picture icon materials to ensure safety while completing a selected chore or activity with 85% accuracy. Before completing a home repair or chore in his house, Max will correctly sequence the instructions so that he completes the chore safely. This will ensure his awareness and knowledge on how to complete these steps.
Once Max can identify the correct sequence of instructions, Max will follow 2 to 3 step instructions to safely perform chores, including home repairs and landscaping, with 80% accuracy. Our third goal, Max will be an active communicator in a conversation with family members when given 3 independent opportunities. We want Max to be successful in conversations and not withdraw when he becomes frustrated. This will be made possible with supports from communication partner training. Finally, Max will participate in conversation with his wife, utilizing the memory book to talk about current events or personal memories 3 to 5 times a week. Max has difficulty recalling current events, facts about his personal life, general knowledge, and who his wife is. Actively participating in conversation with his wife several times a week, using the memory book, will hopefully aid symptoms of Capgras syndrome, Max's overall communication skills, and retaining and recalling information. Spaced retrieval training can be utilized to help progress with this goal. A target question can be, "Who is your wife?" And Max's response can be supported by pictures from the memory book and his wife's physical presence during conversation. We felt these goals were patient-centered and were appropriate for Max's current strengths and weaknesses. We have also established long-term goals that are flexible to the progressive nature of Alzheimer's disease, but keep Max's quality of life at the forefront. The goals noted revolve around maintenance of Max's abilities and the continued use of the compensatory strategies in place. Being attentive with communication partners and maintaining safety during routine tasks is important to Max's daily life now and in the future. Maintaining Max's overall functioning is the constant goal throughout the course of therapy. These goals can be adjusted as the disease progresses and the wants and needs for therapy evolve over time for Max and his family.
We hope you guys enjoyed our presentation and learned something new. Here are 4 discussion questions to consider. 1. What are the primary impairments or deficits that Max presents with that would lead you to a diagnosis of Alzheimer's dementia? 2. How could telehealth successfully be incorporated into an effective treatment for Max? Please include an example. 3. What issues with therapy could arise during telehealth? How would these problems be addressed or modified when working with Max? And finally, number 4. If you were Max's clinician, what is an additional strategy you could provide to Max's wife to aid in his treatment?
And here are our sources for your reference. Thank you again for your time. We hope that this presentation can aid in your knowledge in the future when and if you encounter a client who presents with a dementia diagnosis.